During this presentation of hysterosalpingography, we will review the proper technique for performing a hysterosalpingogram and review the normal anatomy and common abnormalities seen with this procedure. The hysterosalpingogram, or HSG, is a simple X-ray procedure performed using fluoroscopy with intermittent still images for documentation. In general, the actual procedure takes 3 to 5 minutes. The HSG is a relatively low-risk procedure, but does result in ovarian radiation exposure greater than a pelvic CT scan. Thus, repetitive HSG procedures should be avoided and the radiation exposure time during the procedure minimized. This short video demonstrates performance of an HSG. Notice the slow filling of the uterine cavity with radiopaque dye while the uterus is positioned perpendicular to the X-ray beam. Subsequent fill of the fallopian tubes is visualized with free spill into the peritoneal cavity. Unfortunately, many women have preconceptions that the HSG is a very painful test. There is no question that the discomfort is influenced by the experience of the operator. An HSG is performed with the installation of a radiopaque contrast into the uterine cavity. Installation devices include instruments which fit into the cervix, such as a Cohen cannula, or catheters placed into the uterine cavity using a balloon to prevent flow out of the cervix. Very few instruments are necessary for an HSG. An open-sided speculum is optimal since it is easier to remove with instruments in place. The cervix is prepared with an antiseptic and grasped with a single-tooth tenaculum. Gentle, slow placement of the tenaculum, grasping only enough tissue for adequate stabilization of the cannula, is recommended. Distress experienced by the patient because of poor tenaculum placement is often predictor of an overall negative experience with the procedure. Cohen cannulas come with a narrow acorn tip for use in non-Paris patients or a wider acorn tip for Paris patients. All air should be removed from the cannula by injecting contrast with the cannula in the vertical position. Holding the Cohen and applied tenaculum in one hand to occlude the cervix is preferable to attaching the cannula to the tenaculum, since it usually will cause less pain. A balloon catheter may be more suitable for patients with cervical stenosis, since it has a smaller diameter than the tip of the Cohen cannula. A tenaculum is still necessary in order to straighten the uterus during the procedure. Some patients experience discomfort during inflation of the balloon. Both water-soluble and oil-based iodine-containing contrast are used for HSG. The advantages and disadvantages have been debated for years. Water-soluble dye tends to give better detail of the mucosal folds of the ampullary portion of the tube and is more quickly eliminated. Oil-based dye may have consequences of granulomatous formation in the pelvic peritoneum, and escape of oil into the vasculature has been noted. Complications from either of these observations have not been reported. Older reports suggested an increased post-procedure pregnancy rate with oil media, but this appears to be more an opinion than an evidence-based observation. The risks of HSG include infection and a theoretical risk of contrast reactions. Women with suspected tubal blockage should receive a broad-spectrum antibiotic such as doxycycline for 5 to 7 days, starting 2 days prior to the procedure. Women with unexpected distal tubal occlusion should receive antibiotics after the procedure. Prophylactic antibiotics in women with normal tubal fill and spill are not usually necessary. Women with mitral valve prolapse do not require additional antibiotics except in the case of significant intravascular extravasation. A theoretical risk of oil embolism exists with extravasation of an oil-based media. We were unable to find a report of significant morbidity from such a case. Likewise, there is a theoretical risk of contrast allergy, but no reports in the literature could be identified.